This is a video addressing Week 8 Chapter Issue Presentation Review Assignment on Elliot Graves' presentation about end-of-life decisions.
Susan is a 72-year-old Hispanic female who's going through treatment for an aggressive cancer. The treatment is painful and prolonged. She's been your client for the past 5 years, ever since she went through a depressed period when her husband died. You do not have that much experience with end-of-life issues. Her doctor has told her this treatment could result in a period of remission, but that period would probably be brief, and eventually this cancer will likely be fatal. Susan is religious and is struggling with her desire to cease treatment. One of her children supports her ending treatment and only taking medicine for pain. The other child thinks she still has some quality of life between treatments. You're an atheist and are not Hispanic. Susan lives in Florida. The question we'll address is, what are some steps we can take personally and some questions we should ask to ensure we competently assist Susan?
Susan has a history. She's been in counseling for some time now, following depression. Myself as a therapist, I would want to make sure that I found out from Susan how it is that she feels, because Susan is a very religious person. She's very family oriented, and we know how she has included the way that her children feel, and her children have differing views on Susan's possible end-of-life decision. So in talking to Susan, we would want to make sure, first of all, that Susan is making her decision based on the facts. So we would want to make sure that Susan really has all the necessary information from her doctor in order to make a good decision, a well-informed decision about her condition and then about what she wishes to do about it. She's considering ceasing treatment. We know that this is a viable option in all 50 states. So, but we do want to make sure that Susan is aware of other legalities, such as if, for instance, if she loses competence, if there's any sort of dispute within her family, between her family members, about what course of action to take, depending on what course her illness takes. So she would need to be aware of how to possibly write a living will, how to select a surrogate that is in line with her beliefs. We don't really want to sway her in either direction. We just want to make the best decision for herself.
Right.
In this case, Susan's been with me for a long time. A rapport.
Yep.
Aware of her death. I worked through her with that. We have a very deep personal, professional relationship. So even though she is my first client to be going through this particular hardship, I would want to do my best to be there for her in any way that I could. So I definitely would need to educate myself. I wouldn't want to refer her out necessarily unless I felt there was a need to. And I would want to be well prepared to help her in any way that I can. And that might involve also inviting her children. I think she has 2 daughters, or she has 2 children anyway, also to therapy if she's willing, if she wants to include them, or even just to have them there so that she has someone with her while she's telling them how she feels and what it is that she wants to do, what her plans are. The question that this brings up for me in relation to all cases really that are kind of similar to Susan's case, well, I mean, Susan already has the depression diagnosis.
Right.
But her diagnosis I would think it's appropriate. But I am curious as to how that translates, how that generalizes to other cases in which the client may not be as cognizant and may not really, although they may be facing a life-ending decision or a choice that affects hastening their life somehow, then at what point do they lose their autonomy?
Yeah, I think that that issue of competence was one of the hardest problems when I was researching this. Is for one, because it's often not going to be 100% clear. That's an issue. So for me, the idea of weighing competency and autonomy in a case like this, and then also weighing the legal liabilities involved versus confidentiality, were huge sort of ethical balances as in a case. Now Susan's is not as bad as some of the others might be, like you pointed out. It's the generalizing it to others that's the hard part, where you as a counselor may be the only person who realizes at what area on the scale this person is in competency. So you're probably going to be the one who makes at least an initial determination. I don't know if this person is competent. Now, do I need to involve, because of liability, do I need to get an attorney to give me some advice? Do I need to consult out? Probably. And also trying to respect the client's autonomy, because of course once it gets in the legal sphere, there's lots of other considerations when we're trying to make the client's autonomy central to it. And like you pointed out, there's some things we can do now, like getting the right healthcare surrogate for Susan that's may not be available for other clients, but certainly could help her so that if she does lose competence, the person who's now making the decision is someone who agrees with her, who maybe has talked with her about it. And then, of course, as a counselor, we do have the APA guidelines saying we have the ability to maintain confidentiality when someone wants to hasten death. But in a situation where the competence becomes more of a question, at that point we may choose that, hey, this person's not competent to make this decision. We've got to break confidentiality to get some legal authority or some legal advice to decide what to do from there. And I think that is the thorniest, and not black and white, like you said, not black and white at all, because that competence is on the spectrum. If she's depressed versus delusional versus everything else, and you're trying to respect autonomy to the extent that you can. And this concludes our video of end-of-life issues with Susan.